In this lecture, we will discuss ventricular tachycardia, including its origin, classification, mechanism, potential causes, clinical significance, and EKG features that can help differentiate it from other arrhythmias. Ventricular tachycardia, which we will also refer to as VTAC in this lecture, is a wide, complex tachycardia originating from within the ventricles. An ectopic ventricular pacemaker fires faster than the sinus node. So if you look here, what we have going on is this ectopic focus here in the ventricles that's firing and outcompeting our sinus node here, okay? And it's pretty much because it's coming from the ventricles and we have slow cell-to-cell depolarization, we will see these wide complexes, okay? So notice the wide complexes that we see in VTAC. Now there are three general ways in which ventricular tachycardia can be classified. The first is by morphology, such as monomorphic, polymorphic, torsades, and so forth, okay? So torsades de points, that we'll talk about in another lecture, is a form of polymorphic VTAC. And polymorphic just means that there's different morphologies, okay? In these cases, we tend to see the same ones. Okay, so look here, all these tend to appear the same, so we would call that monomorphic. Okay, and that's because they're coming from one focus. Polymorphic VTAC would come from multiple foci, and because of that, you would see different QRS morphologies. Now, the second way that we classify VTAC is by duration. In other words, sustained or non-sustained VTAC. If there are 3 or more consecutive ventricular complexes that terminate within 30 seconds, that would be considered non-sustained VTAC. And if the ventricular complexes continued for more than 30 seconds or required medical intervention as a result of hemodynamic compromise, then that would be considered sustained VTAC. And the third way we classify VTAC is by clinical presentation. That is pretty self-explanatory. Is the patient hemodynamically stable or not? Okay. For instance, if the patient is hypotensive, in cardiac failure, has chest pain, or is mentally impaired, that would suggest an unstable circumstance. So again, there are 3 general classifications how we do this for VTAC: the morphology, the duration, and clinical presentation. Okay, so in terms of mechanism of VTAC, there are 3 main mechanisms. Okay, so we said 3 classifications, now 3 main mechanisms. The first is re-entry, which is the most common mechanism. The second mechanism is triggered activity, which can result from early or late after depolarizations, such as in torsades and digoxin toxicity. And the third is abnormal or enhanced automaticity, in which there is an accelerated abnormal impulse that is generated by some region of the ventricular cells. In another lecture, we're going to look at the common reentry mechanism in detail, which is a bit more advanced for our purposes here. The goal here is to have a general overview and a solid foundation of VTAC. All right, now some causes of VTAC include ischemic heart disease, dilated or hypertrophic cardiomyopathy, Chagas disease, among many others. Clinically speaking, you may already know that VTAC can have life-threatening consequences. For instance, VTAC has the potential to impair cardiac output, thereby lowering blood pressure, causing syncope, and possibly even acute heart failure. This is due to the very rapid ventricular rate and lack of coordinated atrial conduction, that is, the loss of the atrial kick. The presence of pre-existing poor ventricular function can obviously worsen the situation. If the cardiac output falls low enough that myocardial perfusion is compromised, then VTAC may degenerate into ventricular fibrillation, or VFib. As you can see, immediate recognition and treatment, such as with electrical cardioversion, is required, or things can get really bad really quickly. Now, depending on the patient's level of consciousness and hemodynamic stability, the treatment will vary. If the patient is hemodynamically unstable, a defibrillator and advanced life support may be needed. Otherwise, the patient may be treated medically. Okay, let's move on to the EKG, our main focus. So first, you should be aware that there are mimickers of VTAC. One in particular is supraventricular tachycardia, or SVT, with pre-existing intraventricular conduction delay, rate-dependent aberrancy, or conduction over an accessory AV pathway. We won't get into that here, but make sure you keep this in mind when evaluating the EKG and you're considering VTAC. All right, let's take a look at the EKG features that tend to favor VTAC, okay? So if we're looking and trying to differentiate between 2 arrhythmias, these are findings on the EKG that will favor it. Now, this is not an exhaustive list, but it's a great start for you. So what can we see in VTAC? Well, in general, you will see a rapid, regular, wide, and bizarre appearing QRS complexes with T waves that are typically in the opposite direction to the main QRS deflection. The ventricular rate will often be between 120 and 200 beats per minute, okay? So what we're saying here and let's just erase some of this here, is that we have these complexes that are wide, right? Ventricular origin, so we have wide complexes. We said that the T waves will go in the opposite direction to these complexes, so bizarre appearing here is our QRS going downwards, and our ST and T waves going in the opposite direction. Okay, so they're discordant. All right, so that's something we'll see. It'll be regular, so our intervals between our complexes will be the same. Okay, so again, rapid, regular, wide, bizarre QRS complexes with the T waves going in the opposite direction of the main deflection of the QRS. Now, ventricular tachycardia typically has an abrupt onset and termination, so if you're able to catch that, that's something that can be helpful. In addition, AV dissociation is possible in which the atria and the ventricles are beating completely independent of each other. In such cases, it would not be uncommon to see retrograde conduction to the atria. With AV dissociation, you may see P waves and QRS complexes occurring at different rates. If you do see AV dissociation, that's helpful for you because now you have a better idea of the rhythm that you're dealing with, okay? So again, you may have this retrograde conduction where it goes backwards into the atria. And what we see here is, notice we have our QRS complexes, another QRS, okay, as they continue through. And then within these complexes, we're also noticing our P waves. They're buried within, okay? So P waves that are buried within our complexes, and that's evidence of AV dissociation, in which the atria and ventricles are beating completely independent of each other. And this is something that's really helpful when making the diagnosis of VTach if you're able to catch it. Now, another clue that is helpful for diagnosing VTach is the presence of capture and or fusion beats. A fusion beat, which is also known as a Dressler beat, occurs when the sinus and ventricular electrical impulse occur simultaneously and they produce a complex or intermediate morphology of the QRS, okay? So in this case, let's just erase this here and imagine that we have our sinus node that fires and we're able to get down our conduction pathway, but also we have this impulse in our ventricles that's also firing, okay? So we have both of these combining and causing a hybrid morphology of the actual complex. So if you look here, we're looking at these Dressler beats, okay, these fusion beats here, and notice this would be a normal beat, and this is our beat that we're seeing in VTach, and notice how this is a hybrid, okay? And that's happening because we have the sinus node firing and we also have a beat that's occurring in the ventricles from the ectopic focus, and so we get this hybrid morphology or intermediate morphology of our QRS complex, okay? Now, a capture beat is a ventricular complex of normal duration that results from some supraventricular source that fires at just the right time, and it quote-unquote captures the ventricles in the setting of AV dissociation. So again, AV dissociation was that helpful clue that we can see. Now imagine that we have that present, but their sinus node, okay, fires, or some supraventricular impulse fires and is able to get through without this ectopic ventricular focus firing. So because of that, it's able to fire at just the right time and capture the ventricles, and because of that, we get this capture beat that looks like a normal complex, okay? So fusion beat, just as the name implies, is a hybrid morphology, and capture beat, we're just allowing and getting through at the right time to have a normal complex forming, okay? Now, what else do we have? So you may also see wide complexes with an extreme axis deviation, or what we call a northwest axis, okay? In other words, the QRS complexes are positive in lead AVR and negative in leads 1 and AVF, okay? So if we look here, this is where lead 1 would be, this is where lead AVF would be, okay? And AVR is here. Normal axis of our QRS complexes is in this region, okay? Then we would have this rightward axis. This would be our left axis quadrant. Remember, normal axis is from about negative or positive 105 to negative 30, okay, in this region here. And now we're saying that oftentimes, or a clue that can point you towards VTach is this northwest axis, okay? North as in up, this would be north, and this would be west. So in this region, which often we don't really see things there, but this is our extreme or no man's land, okay? And what we see here are positive complexes in AVR heading towards AVR, and then negative complexes in 1 and AVF, okay? So again, another clue that can give us an idea that we're dealing with VTach. All right, so what else do we have? Now, VTAC, if you see complete positive or negative concordance in the precordial leads, so that's leads V1 through V6, this could be a helpful clue. In other words, we're seeing all positive R waves throughout the precordial leads without any RS complexes, or we're seeing all negative QS complexes throughout the precordial leads, okay? So this is concordance in leads V1 through V6 that may suggest VTAC, okay? So they're all going in the same direction in leads V1 through V6. We call that concordance. It can be all positive or all negatively directed. All right, a few more features that can favor VTAC are Brugada's and Josephson signs. Now, Brugada sign is when the distance from the onset of the QRS complex to the lowest point of the S wave is greater than 100 milliseconds, okay? So if you look here, here's our, let's just erase some of this here so it's not in our way. So we're looking first at Brugada sign, okay? And we're saying that we have our initial onset of our QRS complex to the lowest point, okay, of that S wave, if that's greater than 100 milliseconds, okay? That's evidence of Brugada sign and may point us towards VTAC here. Then we have this Josephson signs, and this is when we have notching near the bottom of the S wave, okay? So again, here's our Josephson sign, and this is our notching that we see near the bottom of our S wave, okay? So Brugada's and Josephson sign, both helpful clues. And one last thing that we can see, and is specific for VTAC, occurs in the right precordial leads, V1 and V2, okay? So V1 and V2, those right precordial leads, and we'll see RS-R prime complexes that resemble right bundle branch block. However, in VTAC, the initial R wave of the complex is taller, and this is in contrast to right bundle branch block, in which we have an R prime wave that is taller than the initial R wave, okay? So another clue is right here in V1 and V2, and we're looking at this where we have this RS-R prime complex. Here's our R wave, here's our S wave, another R wave, so it's called the R prime. And what we're saying here is that the initial R wave, okay, let's just erase some of this here. So, okay, the initial R wave is greater in amplitude than that second one, okay? So this here, this portion here is greater than that second R prime. So we have an R wave greater than our R prime. If you see that in leads V1 or V2, that may indicate and point us towards VTAC, okay? So as you can imagine, even with all these clues for VTAC, this life-threatening arrhythmia can be difficult to diagnose even under the best circumstance. All right, let's briefly go through our chart here to make sure we didn't miss anything in review, okay? So again, VTAC, or ventricular tachycardia, is a wide complex tachycardia that originates from an ectopic ventricular pacemaker. We saw that here, okay? We said that this ectopic ventricular pacemaker is firing faster than our normal sinus node or some supraventricular source. We said we can classify it based on morphology, duration, is it sustained or not, and the presentation, is the patient stable or not, okay? Mechanism-wise, we said that reentry form is the most common, okay? And then we also mentioned the triggered activity and enhanced automaticity are also some proposed mechanisms. Some causes, we have some here: ischemic heart disease, dilated or hypertrophic cardiomyopathy, and Chagas disease. There's many others, but that's a basic list for you. Now, in terms of clinical significance, remember, this rhythm can impair cardiac output, cause hypotension, okay, and collapse, acute heart failure. And if the myocardial perfusion falls low enough, we can actually degenerate into VFib, in which we go from VTAC to VFib, okay? So again, immediate treatment is required for this. It can be life-threatening. So some clues, we mentioned abrupt onset and termination, AV dissociation, in which we can see these retrograde atrial conduction are possible. We mentioned the fusion and capture beats, extreme QRS or ventricular axis deviation, okay? We mentioned complete positive or negative concordance in the precordial leads can point us towards this. Brugada's and Josephson sign, RS-R prime complexes in the right precordial leads, V1 and V2, in which we have an R wave. The initial R wave is greater than the R prime wave's amplitude. Now, in terms of the regularity, this is a regular rhythm, okay? We said the beats are just happening at the same intervals, okay? So that's what we have going on. In the rate between 120 and 200 beats per minute, the P wave rate is dissociated from the ventricular rate, okay? And obviously the P to QRS ratio will vary based on whatever the atrial and ventricular rate is. The PR interval, again, often none, or it could be retrograde. if you have something present. Now the QRS interval, prolonged, and one actually other clue that we haven't mentioned is that remember, a prolonged QRS interval is greater than 110 milliseconds, okay? Now if it's greater than or equal to 160 milliseconds, which is 4 small boxes, this is even a greater clue that we have ventricular tachycardia present, okay? So you have these prolonged QRS complexes that are a bizarre abnormal morphology, and you want at least 3 of them present, okay? There's no grouping and no dropped beats. Well, that's the end of this lecture. We discussed ventricular tachycardia, including its origin, classification, mechanism, potential causes, clinical significance, and EKG features that can help us differentiate it from other arrhythmias. I hope you learned something.